Hi, my name is Shavani Somerville, and this is my differential case presentation on patient 1. Patient 1 outline. Review the patient history, demographics, symptoms of patient 1, pathophys from most to least of the differential diagnoses, compare and contrast differential diagnoses, thoroughly explain the pathophysiology of the 3 differential diagnoses using evidence-based research, the main differential diagnoses, diagnostic test, treatment plan, referral, and conclusion. Introduction of the scenario. We have patient 1 who's a female living a promiscuous sexual lifestyle who has a criminal background involving jail time, substance abuse, and resides with several roommates. Patient 1's symptoms are as follows: shortness of breath, chest pain, flank pain, and fever. Patient 1's history and demographic. Patient 1 presents as a single 28-year-old female who abuses 2 types of drugs, IV heroin and opioids. She suffers from post-traumatic stress disorder and has no other medical issues or medications. Although patient 1 is single, she has been sexually active with males and females. She has been inconsistent in protecting herself from contracting sexually transmitted diseases. In addition, she lives in a communal setting, housed with several roommates, and has a criminal history, including jail time. Most to least pathophysiology. I believe that the first one for her, patient 1, would be most likely pneumonia, then HIV, average likely, and a panic attack, which is least likely. Originally, I had chlamydia as my differential diagnosis, but then I switched to pneumonia. Chlamydia was one of the original differential diagnoses. However, pneumonia accurately covers all the presented symptoms where chlamydia failed. Usually, chlamydia presents as asymptomatic. However, symptoms may include pain during sex, abdominal pain, vaginal discharge, bleeding, abdominal pain, and dysuria. While community-acquired pneumonia in patient 1 would be the result of residing with multiple roommates, the spread of bacteria can cause lower respiratory tract infections. Common manifestation of pneumonia includes fever, shortness of breath, flank pain, and chest pain. Pneumonia pathophysiology. Pneumonia is an infection of the lungs from bacteria, virus, or fungi which impair gas exchange. The pathogens enter the body upon inhalation or through other sites. Also, bacteria can spread to the lungs via the bloodstream due to an infection within the body. The microorganisms can get past the upper respiratory defense mechanism to the next line of defense. In the body's attempt to expel the pathogen, the inflammatory or immune response is activated. Inflammatory mediators and immune complexes can damage bronchial mucous membranes and alveolar capillary membranes within the lungs. The immune response creates mucus that are secreted, filling the alveoli with blood and fluid. Pneumonia symptoms related to patient 1. There are several possible community-acquired pneumonia responsible for patient 1's symptoms due to her lifestyle and living situations such as chlamydia pneumonia, streptococcus pneumonia, or oral anaerobic bacteria, to name a few. Patient 1 symptom presentations and pathophysiology are as follows. Shortness of breath can be the result of hypoxia. The infection causes mucus and fluid consolidation leading to SOB. Chest pain can result from prolonged cough due to congested lungs. Flank pain can manifest from prolonged cough and result in weakness, often leading to musculoskeletal pain involving the back. Fever to fight off the infection and the systematic signs of an infection. HIV pathophysiology. HIV can be found in a family virus called retroviruses, which can transform RNA to DNA. The virus has a capability to convert RNA into double-stranded DNA. The newly virus-made DNA infects cellular genetic materials, activating and translating viral information, which results in new virons. The infected cells shed HIV particles which can become dormant, viral genetic materials latent for years. Individuals who are not affected with HIV typically have 800 to 1,000 cluster of differentiation 4, which is CD4 plus cells, whereas a HIV infected individual number is halved by the time the peripheral blood CD4 plus T cell count falls to 200 cells microliter of blood. Depletion of CD4 plus cells profoundly affects the immune system, causing severe reduced response to infectious pathogens, tumors, and presents serious symptoms. Panic attack pathophysiology. Panic attacks can be associated with other mental disorders such as PTSD, which is one of patient 1's diagnosis. Panic attacks are characterized by repeated occurrence of discrete attacks, featuring a variety of physical symptoms such as rapid heart rate, hyperventilation, perspiration, dizziness, dyspnea, trembling, and uncontrollable fear, such as fear of losing control and going crazy, fear of dying. Complications of the mentioned symptoms can lead to shortness of breath, chest pain, lung pain, and fever. Panic attack pathophysiology continues. The central nervous system consists of the neurotransmitters and peptides which influence the physical manifestations of a panic attack. Individuals who experience panic attack lack the appropriate neurochemical mechanisms that inhibit serotonin. Fear or other symptoms included with PTSD causing variation in the autonomic nervous system can feature several different symptoms. The main differential diagnosis is pneumonia. The diagnostic tests for pneumonia are physical exam with CBC to detect leukocytosis, chest x-ray to assess for lumbar infiltrates, blood cultures to identify causative organism, sputum culture to determine positive infecting agent, fungal acid fast bacil culture to identify the etiologic agent. Treatment for pneumonia, which is the main differential diagnosis. Antibiotics can treat bacteria pneumonia, empiric antibiotics based on the causative microorganism. Viral pneumonia can be treated by antiviral medication. Other treatments would include pushed fluid and humidified oxygen to improve breathing and reverse hypoxia related to shortness of breath. Adequate hydration and good pulmonary hygiene would also be part of treatment. Referrals for pneumonia being the main differential diagnoses. Typically, antibiotics can resolve the infection. However, if antibiotics fail as a first line of treatment, then a referral for an appropriate second line of treatment is necessary. Severe pneumonia may require a referral to resolve complications. If patients do not respond to the empirical treatment, then the provider can refer the client to the hospital. Referrals can be sent to facilities that specialize in respiratory health as well. In conclusion, patient 1's case study and the presented symptoms featured many potential differential diagnoses. However, based on her lifestyle, 3 differential diagnoses were found to complement patient 1's case. 1 original diagnosis was changed, chlamydia was changed to pneumonia. Nevertheless, chlamydia can be a cause of pneumonia, which indicated that the previous diagnosis and current diagnosis are linked, which confirms a sound thought process. Thank you for listening.